Uh, Welcome to our annual all-provider meeting and educational event. I'm Dan Wendorf. I'm going to be starting out the program basically to just talk about the state of the organization, that being Health Partners. So for those of you who I've not met, I'm the President and Chief Medical Officer for Mount Carmel Health Partners. I'm a general internist by training. Had a practice in Grove City for about 27 years before I took on this gig, and now I'm doing this full time. So we're going to talk about a bunch of stuff, but we're going to start out with our mission statement. So Mount Carmel Health Partners is the clinically integrated network of Mount Carmel Health System. And this is the mission statement. The mission of Mount Carmel Health Partners is for clinical providers and Mount Carmel Health System to venture collaboratively to provide high quality, cost-effective, coordinated, and innovative patient care in all healthcare settings and to be the premier healthcare provider in Central Ohio. So this is what we're going to talk about tonight. It's been a couple of years, and we call this our annual meeting. It's been a couple of years since we've been able to do this, and I'm so excited that we're able to do this face-to-face tonight. This is the first really presentation I've given face-to-face in a couple of years, so it's really exciting. So some of you are probably brand new to Health Partners. If you're not, you're going to hear of some history stuff that you already know. I'll ask you to just bear with us as we get through that. And then we're going to talk about what's our present state. Where do we stand now as an organization, as a clinically integrated network? We're going to talk about alternative payment models. What is that and why do we care? And then care coordination rate, which is a fancy term that we use for in-network utilization. And then we're going to talk about the tiering of the organization. So let's talk about the history of Health Partners. Health Partners, the current Health Partners was created by putting two physician hospital organizations together. In 2010, we took the old Health Partners, which was the PHO that was specialists only, and CareNet, which was primary care physicians only. We joined them together because what we were looking forward to doing was clinical integration. And clinical integration is basically a network of providers, including primary care and specialist physicians, working with the hospital system and commit to work together with the goal of improving quality of care. So why is that important? If you do that, if you work together for the improvement of quality of care for the patient, and you are truly clinically integrated, you can take many practices which technically cannot work together or go to a payer together. It's against the law. But if you're a clinically integrated network, the FTC says you're doing this for the betterment of the patient's quality, so we're going to allow you to negotiate with the payers as a group. So that's what clinical integration is about. So this is a launch photo. This is launch day was April 1st, April Fool's Day, 2011. Not my choice of day, but that's just how it worked out. And we started with one provider. That was me. I signed on April 1st, and then we've gone from there. So in 2014, Health Partners, which was a 50-50 joint venture, the docs owned half, the hospital owned half. We realized in 2014 that we were going to be starting to move towards contracts that included risk, downside risk. There was going to be capital needs. And at that point, we came to the realization that what we needed the hospital for was that capital. So what happened at that point, all the docs sold their shares to Mount Carmel. Mount Carmel became the owner of Mount Carmel Health Partners, the sole owner. But part of that included the fact that we wanted the organization to be maintained as a physician-led and physician-guided organization. So part of the stipulations of selling to the hospital system that was that we would always have a supermajority of board of director seats for practicing providers. And this is our current board of directors, always chaired by a physician. All of our subcommittees are chaired for, and at least half of the committee members are practicing physicians in our organization. We want to truly not just say it, but be it, physician-led and physician-guided. So what's the present state? Here's our geographic picture. So you can see all the different practices on this map. Health Partners Clinically Integrated Network, just about 3,000 providers at this point, starting with that one in 2011. It's a key pillar to Mount Carmel's strategy. Mount Carmel and Trinity Health have decided that moving towards value and away from fee-for-service is where we need to go. And because of that, the CIN model is part of that. We're dedicated emphasis on population health management. And compared to the Central Ohio market, health costs and utilization of Health Partners attributed patients are significantly lower and are continuing to trend lower. Again, it's a physician-led structure, and we have steady improvement in quality metrics throughout the years that we've been doing this. Let's talk about the providers. Current provider total, 2,980 providers. Of that, 1,989 are docs, and of that, about a third are primary care, about 2/3 are specialists. Just a few years ago, we started including advanced practice providers. We now have 991 of those who are also part of clinical integration. They are full members of our organization. So these are some of the Health Partners resources that your practices can use. Population health. We have a pharmacy team that interacts with the patients to talk about metrics like statin use in diabetics, statin use in cardiovascular disease, making sure that they're getting generic prescribing to a good level, making sure the patients are filling their medications so that they have good continuation of the medical response. We have care managers with our LPNs and RNs who do a multitude of tasks, but they do pretty much whatever you think we need to take care of the patient population, the population that we are accountable for. So our care manager nurses will do transitions of care call. Okay, they'll call a patient after they leave the hospital, or if they're in the emergency room and they leave the emergency room, they'll get a call in a couple of days to make sure they got their medications, they know what they're supposed to be doing. The transition from one level of care to another level of care has been shown repeatedly to be the most dangerous days in a patient's life. Those are the times that things fall through the cracks. We have pharmacists who are addressing the needs of every patient that leaves our hospital. And even to this day, just this morning, our data showed that of those interactions, 38% of the time, the pharmacist needed to take some kind of initiative because the patient was either their meds went to the wrong pharmacy, they had the wrong dose, they didn't understand the instructions, something that the pharmacist needed to do to make sure that patient was safe with their medications. So those are the things that the pharmacy team is doing. Care managers are doing transitions of care. They're doing longitudinal care. So patients that are very chronically ill will have a patient manager that will call them and talk to them and be there for them to help them navigate what can be a very difficult milieu of medical care. We have a team of social workers for behavioral health needs. As you all know, COVID has brought this to the fore and really caused a huge increase in the problems in behavioral health, especially isolation. Our social workers are working on that. We have community health workers that are in the community, they're part of the community, and in many cases, they're the best ones that can advocate for us. And one that's not on this list because it just started last month, we have included the community paramedics in our organization. So we provide them with lists of patients. Many times, the one person that's most trusted in the community by the community is a paramedic. They can get in the door when no one else can, and they do a fantastic job. Our quality team, and Anita's in the back there, she leads our quality team of provider operations support specialists, practice operations support specialists, POSS. We love our acronyms here at Mount Carmel, and Health Partners is no exception. These POSSs are in the practices, helping to close those quality gaps. They're finding those patients that need an A1C done or their A1C is out of control, and how can they help to close those quality gaps? They're there as a resource to our providers. We have a risk adjustment team. It's critically important, and I'll talk about this later in the presentation, that each and every patient that we document their true burden of illness. Everything in the future is going to be risk adjusted. All of the metrics that you're going to be held responsible for are going to be risk adjusted. So it's not going to be okay anymore to say, my patients are sicker, because somebody's going to look right back at you and say, prove it. Document the burden of illness so that we know how sick these patients are, and then we'll risk adjust everything. Provider engagement is the team that's sitting in the back that helped put all this together, the Kellys, Kelly and Kelly. We're out at the practices. The primary care practices get a visit every quarter. The specialty practices, less often, but on an ad hoc basis, but at least twice a year. We're out in the practices, sharing data, talking about what we need, what we need, and what does the practice need from us. Credentialing is a critical component of what we do. Kelly also runs that, and that is getting the credentialing done so that all of the payers for all of the contracts, you have a one-stop shop. You can get your credentialing done through us, and that gets you into a bunch of different programs. And then operations, Ross Cirincione couldn't be here tonight. He's getting ready for the Indians game tomorrow. He's a huge fan. And the Guardian game. Okay, I'm going to call them Indians from now on. I'm sorry, Dennis. That's just the way it's going to be. So he's a head of our operations, fantastic, smart guy, really keeps us on our toes and does a great job with the finances. So let's talk about alternative payment models. Alternative payment model, what is that? Well, essentially, it's anything that's not fee for service. Okay, it's a payment model that is predicated on taking good care of the patient and the quality that you provide. Clinically integrated network, we already talked about what that is. An accountable care organization, often a CIN, often a CIN or a clinically integrated network. It's an organization that takes accountability for quality and financial aspects of the care of a defined population. And here's a glide path. This shows you the different payers that we have contracts with. And at the bottom left, you'll see loose management, fee for service. As you go up towards the top right, what you see is Medigold. That's highly managed care, full capitation, full risk. And along that line are all the different products that we are taking care of. The farther you get towards risk, they call it risk for a reason, the more risk you have, but the more benefit you get if you do things right. And so it's very important that we keep an eye on all of these aspects, because some of these products, if you do poorly, the number's not zero. You're writing a check back to the insurance company. So how do we do this? So here's just another grid to show you those different plans and where they stand. Down at the bottom here, low risk. These are upside only, under 65 years old. Upside only plans. That means if we're successful, we get some dollars. If we're not successful, it goes to zero. We don't get anything. Then you have the downside risk, which is if you do well, you make a significantly more percentage of that gain share. If you do poorly, you're writing a check back to the insurance company. So MLR, you'll hear this. Some people call it different things. Medical loss ratio. This is the key target because it is the measure of how efficiently you're taking care of the patient population. It is essentially the percentage of the premium dollar that's being spent on healthcare. 85% is normally what every MA plan is shooting for. And as a matter of fact, for Medicare Advantage, if they spend less than 85 cents of the premium dollar on healthcare, they got to give that extra money back to Medicare. So they have a floor there. That's why when they work with us, we can help them with that, because the work that we do goes into the medical loss ratio. So what are the levers for success in a program that has a medical loss ratio target on a financial basis? Well, there's three: quality, utilization, and documentation and coding. So let's talk about quality. Quality metrics are important, especially for Medicare Advantage, because the star ratings determine the star rating of the program, of the Medicare Advantage program. And if they're a 4-star, they get a bonus in their revenue. So they get more premium. So the higher the premium goes, the lower the medical loss ratio goes. HEDIS metrics are also part of the gain share methodology. So if you're doing well in a program and you're saving a lot of money for the insurance plan, many of them have a gate that says, yeah, but we're not going to give you any share of that money unless you also provide great quality of care. So it's important to have the quality. Utilization, it's pretty clear that's part of medical loss ratio because that's on the expense side. So this is the expense of inpatient care, outpatient care, emergency department care, and skilled nursing facility care. These are the four big places, big buckets of cost in the system. As much as we can decrease the utilization of these different buckets and move one to another so that the patient that does need care gets their care at the most appropriate and cost-effective level, the better we do. Burden of illness. It's critically important, especially in Medicare Advantage, to document and code every diagnosis for every patient because the Medicare Advantage plan gets paid a premium based on the illness of the patient. Sicker patients will utilize more healthcare dollars than healthier ones. The severity of illness derived from documentation and coding allows the CMS, Medicare, to determine how much money should go to that insurance plan to take care of that patient of that risk. The model is predictive and it runs on a one-year cycle. So many of you have heard me say, from the standpoint of CMS, from this coding, if you have a patient with an amputation on January 1, that leg is grown back until you document again that there is an amputation. So it's 1 year, it's good for 1 year. Every year we need to redocument every illness, every burden of illness. These are the hierarchical condition categories. I'm not going to belabor this, but just to let you know, there's demographics, the age and gender of the patient, the Medicaid status, their disability status, and whether they have end-stage renal disease is the baseline for their RAF score. And then above that, it's the diagnoses that you document in your notes and in your billings. The national average every year gets reset to 1. 1.0 is the average risk of a Medicare patient. Yes, sir.
When we see it, that will pop up in the box. Diagnoses, they're asking us to document those and say something about each one.
Sure.
And we typically trust that metric box that anything not in there has already been addressed.
What system are you using? You should be able to trust that everything in that box, and if you find that you can't trust it, that's the guy to talk to, Dennis Ruppel. You just smack him upside the head because he's in charge. But yes, the box in Epic should have all of the previously diagnosed HCCs. So what it's asking you to do is it's saying, I want you to revalidate something that's already been diagnosed. Now, if it's a new diagnosis, obviously it's not going to be on that list. You still want to do that.
But I can trust if I see in the chart in their problem list, that's 17 HCC diagnoses, and only 3 are in that box. I only need to get those 3 to make sure they're all done.
That's correct. So how did we do? This is 2020. 2020 was COVID year. You all remember it. Started around March. Things went haywire for the hospitals, for everyone, for the nation, for the world. We were successful in 2020 because we were at downside risk with several programs and utilization went through the floor. Okay, so the insurance plans made a ton of money because they didn't reduce their premiums. They got all that premium money. They didn't have to spend out very much because utilization was low. And then if there was money that was going out for COVID, the government was covering that. So in 2020, we were successful in the programs that you see starred here. So we missed MMO and UHC and the colleague health plan. Everything else, we were successful, and successful means that we earned a gain share in those programs. It was a significant number of dollars, and half of that was shared with the providers. In 2021, and this is the latest data we have, 2021, it hasn't even been finalized yet. It's October of 22. We'll get our final reconciliations towards the end of this month. But these are the plans that we were successful on in 2021 or anticipate that we will be. And the 3 that we're not going to be successful, or that doesn't look like, I take it back. We just heard today MMO is going to be successful. So Anthem ACO and Aetna ACO, downside risk under 65 commercial plans. Commercial plans are tough. They don't have the same HCC adjustment that Medicare Advantage do. So it's a very difficult thing. You'll see that none of our downside risk programs are commercial. There's a reason for that. Very hard to be successful in a downside risk program in the commercial market. So we don't go there. But like I said, they call it risk for a reason. So let's talk briefly about care coordination rate. Care coordination rate, again, in-network utilization, is a key component to clinical integration. If we want to take great care of our patients, have good quality, we need to make sure that they stay inside the network, that they stay inside that bubble wrap that we can surround the population with. And that means all of our docs, all of our providers referring to each other. So if you have a patient that needs a referral, they need to be referred inside the network as much as possible. Now, what are the exceptions? Patient choice is always an exception. Okay, patient always has the choice. If the patient has a choice of a doctor, just tell me to shut up if I come and say, why are you sending these guys? Because the patient choice is always number 1. Other than that, if there's a specialty that we don't have inside the CIN, go ahead and refer outside, but let us know, because we want to have network adequacy. And Kelly will work diligently to get that doc that you're referring to inside our organization so they are part of the organization. Turning to the organization, this is a must in downside risk contracting. All of you here came here tonight. You took time out of your day and your evening to be here to hear this presentation. And that tells me something. That tells me you're high performers. You're the ones that are doing a good job because you're dedicated, you're engaged in this. What we can't have, when you get to downside risk where we're writing that check, we cannot have practices that don't engage inside those contracts. They can still stay in the clinically integrated network, and we want each and every one of them to reach tier 1 status. But I can tell you, I looked in advance at the list. You're all tier 1. Everyone in the room, as far as I could tell from the list that I saw, is tier 1 right now. If you were tier 2, we would be talking to you about getting you up there. But what we don't want to do is have high performing practices suffer because some of the practices are pulling down our numbers, because we're all in this together. And it's important that we all work together to make sure that we get this done. So again, our goal is for all of our practices to meet the tier 1 status.